Myopathies. So what is basically this cardiomyopathy? So cardiomyopathy, it is a group of diseases of the myocardium which is not due to these five factors. That is, which is not due to ischemia, not due to increase in BP, not due to this coronary artery diseases, not due to congenital heart disease, and due to active inflammation. So a group of diseases which is not involving this. So primarily there are three type of cardiomyopathy. One is the dilated cardiomyopathy, then the hypertrophic cardiomyopathy, and then the restrictive cardiomyopathy. So in the dilated cardiomyopathy, you can see that here the left ventricle is shown. The left ventricle and sometimes the right ventricle, they both get dilated. That is, they actually, as you can see in the figure, they actually get ballooned out. And there is actually, you can see that it is actually like ballooned out. That means the blood can be accommodated in this left ventricle. So there is actually no diastolic failure. Instead, it is unable to contract the blood to the aorta because it is dilated. So there is actually systolic failure, systolic dysfunction or systolic failure in dilated cardiomyopathy. This dilated cardiomyopathy, it is the most common cardiomyopathy that is seen. That is 90% of cases. Whereas this restrictive cardiomyopathy, it is the least common that is seen. And in dilated cardiomyopathy, you can see that it is actually involving throughout. That is, there is global. Global means it is involving throughout. So there is global hypokinesia. Global hypokinesia. In hypertrophic cardiomyopathy, you can see from the normal heart that there is hypertrophy of the myocardium, and the more hypertrophy it is seen, so this is actually the septum. This is the left atrium and left ventricle, and this is the septum. More hypertrophy is seen in the septal near the septum, and especially on the upper side. So when there is ventricular systole, so when the ventricle tries to contract, the septum actually they decrease in length, right? So due to decrease in length, this will actually bulge out, and they will actually cause obstruction to the outflow from the left ventricle. So this hypertrophic cardiomyopathy, you can see it is asymmetric. So this is also called as asymmetric cardiomyopathy. Asymmetric cardiomyopathy. Hypertrophic cardiomyopathy. So I will give you another example of a person. If a person is hypertensive, or if there is a stenosis, if there is an aortic stenosis, here also there will be ventricular hypertrophy. This is a normal heart, so if it is getting hypertrophied, sometimes it will also get hypertrophied. But in this case of hypertrophy, that is aortic stenosis, and even in the case of hypertension, it is actually symmetric. The hypertrophy is actually symmetric, whereas in hypertrophic cardiomyopathy, it is actually asymmetric. So this cardiomyopathy, as the hypertrophy is causing the obstruction of its outflow, this is also called as hypertrophic obstructive cardiomyopathy. So how we can differentiate between these two, that is the dilated cardiomyopathy and hypertrophic cardiomyopathy. So in the dilated cardiomyopathy, you can see that there is hypokinesia, that is heart is less contracting. Whereas in hypertrophic cardiomyopathy, you can see that it is hypercontracting, that it is more contracting. So in dilated cardiomyopathy, when you are looking, you can see that there is on echocardiogram, there is actually a big heart. So actually the echocardiography, it is actually the investigation of choice. And in echocardiography, you can see that there is, so you can see that there is a large cavity, and it is actually, the myocardial wall is actually thinned out. So when you are taking an echocardiography of the hypertrophic cardiomyopathy, so you can see there is hypertrophy, and this hypertrophy is asymmetrical. That is, on the septal region there is more hypertrophy. And looking through the echocardiography, you can see that the cavity is actually banana shaped. So the cavity in dilated cardiomyopathy, it is like balloon like, whereas in hypertrophic cardiomyopathy it is actually banana shaped. Banana shaped. So now what happens in the restrictive cardiomyopathy? In restrictive cardiomyopathy, there is actually pathological infiltration. So due to this pathological infiltration, you can see that there is actually the myocardial wall. So this actually becomes thick and firm. It actually becomes thick and firm, thick and firm. So the blood which is present in this left ventricle, it is actually, it actually contract. It can actually contract. That is, there is systole, but then after the blood actually must come from the left atrium to left ventricle. So at that phase it will be in diastole. So this diastolic function, it cannot be performed by this left ventricle in restrictive cardiomyopathy. So that there is here there is actually a diastolic failure. Here there is actually a diastolic failure. This pathologic infiltration, it can be due to deposition of, due to amyloidosis, or due to sarcoid granuloma, or it can due to iron overload conditions such as hemochromatosis. So what I have said until now is that in dilated cardiomyopathy, it cannot actually, the ventricle, it is actually, there is actually systolic failure. That is, the ventricular systole is affected. Whereas in hypertrophic cardiomyopathy, so there is actually an obstruction. There is a dynamic obstruction to the left ventricular outflow. I am repeating, it is a dynamic obstruction. Whereas the static obstruction, it can be seen in stenosis condition. It is because it is dynamic obstruction of the left ventricle, because during this there is actually the anterior mitral leaflet. So during ventricular systole, the anterior mitral leaflet, it actually move towards the ventricular septum during this systole, and there is actually a dynamic obstruction to the left ventricular outflow. This hypertrophic cardiomyopathy, it is one of the most common cause of sudden death in young athletes. So in young athletes, so due to vigorous activity, it is one of the most common cause of sudden death, a sudden unexplained death. And so during autopsy, when they are doing autopsy, so they will find hypertrophic cardiomyopathy in their heart. This is how they finds it. So what is the reason behind it? So when these persons with a hypertrophic cardiomyopathy, when they are doing activities, a lot of activities, so more activity means there is more obstruction. There is a dynamic obstruction. So the blood that is reaching the aorta decreases. Moreover, during activities, most of the arterioles will relax, and this will actually be some of the blood will be stored in this peripheral arterial system. That means less blood is present at the aortic region. So there is actually less blood to perfuse the heart through the coronary arteries. So when less blood is going to the coronary artery, there will be severe ischemia, and there will also be a conduction abnormality, and there will be fatal cardiac arrhythmias. And now in the restrictive cardiomyopathy, the diastole is affected. So now I will be going details. So about dilated cardiomyopathy. This dilated cardiomyopathy, it can also be called as congestive cardiomyopathy. And in this, so in dilated cardiomyopathy, there is actually progressive cardiac dilation and contractile dysfunction, that is systolic failure. So this is actually a normal heart, and the blood, this is actually the right ventricle, and the blood from the right ventricle, it is going for the oxygenation to the lungs, to the respiratory system, and after oxygenation it is coming into the left atrium, and then it is coming into the left ventricle. So this is what is normally happening. So in the case of the dilated cardiomyopathy, the left ventricle, there is actually systolic failure. That is, the left ventricle, it is difficult to contract the blood, contract the left ventricle. So the blood is not getting ejected. So that means there will be an increase in the pressure in the left ventricle, and then due to back pressure, there is increase in the pressure of the left atrium. Then the pulmonary venous pressure will increase, and finally the pulmonary capillary pressure will increase. And the increase in the pulmonary capillary pressure, it can lead to edema. The increase in the pulmonary capillary pressure, it leads to edema. That is pulmonary edema. And then the clinical features due to this pulmonary edema develops. That is, the person can develop cough, the person can develop difficulty in breathing, that is dyspnea, and he can develop paroxysmal nocturnal dyspnea and even orthopnea due to this pulmonary edema. In the lower base of the lung, you can find there will be crepitations. That is crepitations on the lower base of the lung. So similarly, there is also right ventricular failure. That means the right ventricle, it is unable to pump the blood due to systolic dysfunction. So the pressure in the right ventricle increases due to a back pressure that is developed. The pressure in the right atrium increases. The pressure in the right atrium increases. So the cable system, that is the superior vena cava, the inferior vena cava, it is unable to pass the blood into the right atrium. So the venous pressure will rise, and here there will be JVP, that is a jugular venous pressure will also rise. So there will be elevated JVP. Due to this, so this is a liver, and the blood from the liver, it cannot be drained into the inferior vena cava. So due to this, there will be hepatomegaly. So in liver there will be hepatomegaly, and here you can see that. So this is a systemic veins. This is the systemic veins, and this is the capillaries, and this is the systemic arteries. So as there is actually back pressure that is developing and increase in the pressure in the inferior in the caval system, so there is actually back pressure in the systemic venous. So the systemic venous pressure will increase, and so the systemic the systemic capillary the pressure will increase, and there will be generalized edema. So due to that, there will be generalized edema, and there will also be ascites. Ascites will be seen. So altogether we can say that this patient, he will be having both left ventricular failure as well as right ventricular failure. Due to left ventricular failure, there is actually pulmonary congestion and the features. Due to right ventricular failure, there is actually systemic venous congestion and its features. So that is why this is called as congestive, this dilated cardiomyopathy. It can also be called as congestive cardiomyopathy. So actually he is developing the features of congestive cardiac failure. So this can also be called as congestive cardiomyopathy. So altogether we can say that this dilated cardiomyopathy, it is actually a cause of congestive cardiac failure. So due to the dilated cardiomyopathy, it can lead the congestive cardiac failure can form. And one more thing in the clinical feature is that, so due to the left ventricular failure, there is actually a decrease in pulse. And one more point to note is that there will be an added sound, that is S3, that is a third heart sound. So it is because actually the ventricle, it is overfilled. Actually the ventricle is overfilled, and during the diastolic phase, more blood, you can see more blood is rapidly filled during the diastole of left ventricle, and that is the reason for the third heart sound. That is the rapid filling to the overfilled left ventricle during diastole. So a more point to note is that, so in advanced cases, actually you can see that, so there is pathological dilatation of the heart. So this is actually the mitral ring. You can see that this is the mitral ring. So this is actually the mitral annulus. So normally what happens is that during the systole of the ventricle, that is when the ventricle is contracting, ventricular systole. So this is the mitral valve. They actually, it becomes like this. That is, they actually close. It actually closes. So when there is actually the dilatation of the heart, so correspondingly you can see that this mitral ring, there is a mitral ring, it also dilate. That means this is the mitral leaflets, and you can see that there will be actually mitral, the leaflet will be everted upwards. It will be like this, that is, it will be everted upwards, and there is actually mitral regurgitation. So there will be functional mitral regurgitation, and on the right side there will be functional aortic, functional tricuspid regurgitation. See, due to this ballooned out heart, and there is actually abnormal blood flow, hemodynamics, there is abnormal blood flow in the heart. So there is actually, they will develop thrombus. So the thrombus will be formed in the heart. So this thrombus, it can, if it is formed in the left heart, if the thrombus is formed in the left heart, it can go to the, through the aorta, it can go to the systemic artery and it can cause embolus there. Whereas if the thrombus is formed in the right heart, it can actually go to the lungs, through the, it can actually go to the lungs and cause pulmonary embolism. So now we can look what are the causes of this dilated cardiomyopathy. So the causes of the dilated cardiomyopathy, you can remember by A, B, C, D, H, P. So, A is intake of alcohol. The intake of alcohol is strongly associated with the formation of dilated cardiomyopathy. So then, next one is a beriberi. Beriberi. That is, if there is chronic alcoholic diseases, there will be thiamine deficiency and there will be beriberi. It can lead to dilated cardiomyopathy. So, a virus can cause a cardiomyopathy, that is a Coxsackie virus. So, that is a Coxsackie virus. Then, use of cocaine. It can cause cardiomyopathy. That is, it can cause this dilated cardiomyopathy. And moreover, this cocaine can make there is a coronary vascular spasm and it can induce ischemia. Then the Chagas disease. Chagas disease. It can also, it is another cause. Then there are certain chemotherapeutic drugs which can cause dilated cardiomyopathy. That is doxorubicin and daunorubicin. Doxorubicin. Then iron overload conditions such as hemochromatosis. Hemochromatosis. So this iron overload condition, it can also cause liver cirrhosis. So this hemochromatosis, it can lead to dilated cardiomyopathy or it can lead to restrictive cardiomyopathy. So when it affects the pancreas, it leads to diabetes. When it affects the liver, it can lead to cirrhosis. Then another condition is the pregnancy. So due to some reasons, there is actually peripartum cardiomyopathy that is occurring in the later phase of pregnancy or after birth up to 5 months, that is postpartum. So these are the causes of the dilated cardiomyopathy. So now about the genetic cause of the cardiomyopathy. So now about the genetic cause. So the majority of causes of the dilated cardiomyopathy, it was idiopathic, majority of cases. But recently they have found that certain genetics are involved in this. So one such condition I will be explaining. So this is a cardiac cell, and here you can see this is a contracting unit, that is a sarcomere. Here you can see the actin and the myosin. So this is actually the plasma membrane and this is the extracellular matrix. So there is a protein that is called this diastrophin, which is linking the cytoskeleton. So this cytoskeleton to the extracellular matrix. So the gene which is encoding for this diastrophin, there is a gene, and that gene which is encoding this diastrophin, it is getting mutated. So due to the mutation of this diastrophin, the force generating mechanism of the myocardium, it is unable to function well. That is this sarcomere. So by the Laplace law, the pressure is equal to tension generated in the wall divided by radius of the cavity. So as more blood is coming and there is actually progressive dilatation. So you can see that the radius is increasing progressively, and as the force generating mechanism it is impaired, it is unable to generate the required tension. That means there is reduced tension. So you can see that there is dramatically decrease in the pressure, a very decrease in the pressure. So the ventricle is unable to generate such pressures to eject its blood. That means there is systolic failure. So In some patients, we can see a different pathology. That is, the mitochondrial proteins. That is, there is oxidative phosphorylation for the synthesis of ATP. So, due to defect in such proteins for oxidative phosphorylation, due to defect, it is unable to generate the ATP. So, this ATP is required for the force generation. So, that has been defective. So, either there is a functional defect in some patients, and in some other patients, there is a structural defect, that is dystrophin, that is leading to a decrease in tension. There is also another pathology, that is the beta. There is some in the cardiac myocyte, there is beta oxidation of fatty acid to generate energy. So the enzymes which is involved in this beta oxidation of fatty acid, they becomes mutated, and hence energy is unable to provide. So that the force generating mechanism are impaired, and it can lead to dilated cardiomyopathy. So just giving an overview. So the cardiomyopathies, they are of three types. That is dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. So 90% of cases, that is the most common, is the dilated cardiomyopathy, and the least common is the restrictive cardiomyopathy. So to treat the patient, we can decrease the preload of the heart. So then the diuretics can be given, and angiotensin receptor blocker can be given. So we can cause arteriolar dilation and venodilation. So the preload of the heart is reduced. So due to arteriolar dilation, there is heart has to pump against less resistance. So due to the dilatation, the conductive pathway becomes defective, and they will end up with arrhythmias. There will be dangerous arrhythmias.